Oh, did you have a question?
Yeah, I'm sorry. Sorry, I feel like we're in the wrong room.
Oh, what room were you looking for?
No, it says 7. I will definitely not be talking about any content. So, just feel safe, you know. I'm just thinking, I get the money that it grows, but this is separate. Ready? More excited to come. That's a little bit hard, but I can still be definitely more excited.
Okay. County, comment. I can put a look at it for you.
Sorry, how it's looking for animal resources and health records.
That's in red. It's a color red.
Yeah.
Sorry. I
Can't believe it's invasive.
It's like there's two things. Yeah.
I missed it. I was with Becky and I thought it was just send it out, let you know.
Yeah, so awesome. Okay, so everyone in the room is here for the easy class, right? Yes, okay. The emergency department. Okay,
I reckon.
well, thank you everyone for being here. I know this is the last presentation of the day. So we have Dr. Michael Pulia here. He is a tenured associate professor in the Department of Emergency at the University of Wisconsin-Madison School of Medicine and Public Health. He's also affiliate faculty in the Department of Industrial and Systems Engineering. Dr. Pulia's emergency care for infectious diseases, or ECID, is that how you say it? ECID services research that focuses on improving the diagnosis, management, and prevention of infectious diseases in the emergency department and downstream care settings, with an emphasis on systems and driven by infectious and emergency. His work aimed at reducing diagnostic error and improving antibiotic stewardship has been supported with funding from both inter and external sources, including the AHRQ and the Wisconsin Partnership Program. Regularly invited speaker at national and international conferences, including the Society for Academic Emergency Medicine, ID Week, and the International Symposium on Intensive Care Disease, and now the Illinois Summit. Yes. The regional including invited editorials and scientific journals of pediatrics, of the American Pediatric Society, and the American Medicine. In 2022, the National Academy of Medicine, John A. Academy for Diagnostic Excellence, or direct means of including diagnosis of pneumonia in the. So it's no, that's an incredible bio. I had to read every word of it. So with that, I will hand it over to Dr.
Thank you so much for that introduction, and thank you to the brave ones who want to tackle stewardship in the ED. I'm very proud that there's a good crowd here that is taking on this challenge. It's not easy, like herding cats a little bit. So let's just dive right in here. So just some acknowledgments. These are some funding sources. I have no financial disclosure related to this talk. We could try to make it interactive. Feel free to raise your hand. I don't get offended by getting interrupted. I'm happy to stop and engage on a topic in the middle versus saving everything for the end, although we will have time at the end for questions if you want. All right, so we're going to start with a fact that I think is always pretty jarring when you see this, and it's pretty amazing actually when you think about it. So the commercial airline industry, when you look at the total flown passengers since 2009, 8 billion flown passengers with 0 fatalities. They've had a few close calls this year, doors falling off and things, and you hear about wheels falling off. I'm getting a little nervous, but that I'm gonna have to change this slide, but I hope I never have to. But essentially, it's an incredible record of safety, right? When you think about that. Now let's compare that to medicine. This is a number that's kind of thrown out often. You see the reports, and this is even in more recent reports increasing. Some people think that medical errors are among the leading causes of preventable death in the US every year. So at least conservatively, several 100,000 deaths due to medical errors every year. So that's a pretty stark contrast between two very complex industries that have high stakes and a lot of system complexity. I think if I had to boil it down to one word of why I think this is, and I think there's probably a bunch of words we could think of, but the one that I think probably has the most impact that we don't think about enough is design. Uh, when you think about it from a systems design perspective, it's almost that the healthcare system is in many ways designed to fail. And I think a lot of the way we think about improving stewardship is from that systems engineering, ergonomics, or human factors design lens. So, in terms of the learning objectives, first I want to convince you that emergency department stewardship is important. Hopefully, just by the fact that you're in this room, you'll agree with me. The second, we're going to do a crash course on human factors and systems engineering and how we could apply those methodologies to improve stewardship in the ED specifically. And then we're going to try talking about specific application. We're going to talk a little bit about UTI and some of the work we've done there, and then a little bit about skin and soft tissue infections as well. Sound good? Any questions? Okay. Again, some of the stuff might be preaching to the choir, but AMR by the numbers is obviously a huge deal. We've all heard the sort of apocalyptic quotes about that. You've probably heard a bunch of them today already. There's many millions of resistant infections every year, obviously C. diff and associated deaths with that. And also one thing that we often forget is that antibiotics are a patient safety risk, individual patient safety risk. We've written about the risk of organ failure with patients being exposed to antibiotics, particularly older adults are vulnerable with drug-drug interactions, other toxicities, and ED bounce back visits related to antibiotics that in many cases weren't necessary at all. This was a group out of the Lancet that in 2022 that probably put out the most striking trends, and a very credible group that does projections as well, saying that AMR will be the leading cause of death worldwide by 2050. So kind of another shocking statistic there. This is from an article, if you aren't familiar with the 5 Ds of stewardship, which I'm assuming most everybody is, but this was our attempt to get the word out to the emergency medicine community. We authored this a couple years back in sort of a specialty journal newsletter type of thing called ASAP Now. Just talking about the 5 Ds, you got diagnosis, getting the right drug, the right dose, the right duration, and then de-escalation. So thinking about what appropriate culturing do we need to be doing in the emergency department to give our downstream friends the best chance of tailoring and optimizing therapy. The one that I'm most interested in as a physician is the diagnosis piece, because essentially a significant amount, I'll show on some of the other slides, significant amount of diagnosis occurs in the ED. That's across the board, and that has a lot of downstream implications for what happens after they leave the emergency department. One of my proudest achievements is that we were successfully able, a group of myself and a few others were able to successfully lobby the American College of Emergency Physicians to put out a white paper and issue a policy statement. The best line is at the end there. The ASAP supports and encourages the engagement of EPs, emergency physicians, and EDs in antimicrobial stewardship efforts at all levels. So essentially, it's like codifying that stewardship is a core competency and excellence point for emergency departments to focus on. So that was a couple years back that we got that through, which is awesome. So just a little more specific about the ED, it's really the nexus, has become the nexus of the healthcare system. Almost 1 in 5 patients will visit the ED every year. Almost all admissions now, elective admissions, are coming through the ED. Or I'm sorry, non-elective admissions. So essentially people that are coming in with unscheduled care, almost all of those admissions nationally are coming through the ED now. And also we take care of 30% of ambulatory acute care visits. So they're not, things that would typically take place maybe in a physician's office or in urgent care. 30% of those are happening in EDs. We use a ton of antibiotics. Second most common drug that we prescribe. Almost a quarter of our visits involve an antibiotic prescription. And there's significant data of inappropriate carryover. So essentially, if the emergency department initiates therapy for an inappropriate diagnosis, in many cases for days or doses at least, those are continued on the inpatient setting. And in the ambulatory setting, there's nobody checking up on those scripts. They're going to be done by the time they go see their doc for a follow-up visit. Let's talk about raising the bar. So what are our pinch points? We have high rates of prescribing for UTIs for patients that have no symptoms, localizing to the urinary tract. That's a real big hot button issue. When I speak to my colleagues about this, people get real fired up about that. Like find you in the hallway afterwards, fired up. Okay. Skin and soft tissue infections, we failed to adhere to best practice guidelines of these in about 90% of cases, according to the national data that we have. Respiratory tract infections, we have high rates of prescribing for completely non-indicated conditions, whether that be bronchitis or otitis media for viral conditions, but also if you dive into it, a lot of what we call pneumonia is very questionably actually pneumonia, which is sort of a whole other talk that I could give on that. All right, Baby Yoda, drink break, any questions with that part? You convinced ED is kind of important? Okay. All right. All right. Crash course on human factors ergonomics. So Dr. Chapanis is considered sort of the godfather of human factors. So in the US, we call it human factors. Everywhere else in the world calls it ergonomics. We have to be weird, just because, why not? And this is just sort of the definition of what human factors is considered. So we're trying to apply information about human behavior, abilities, limitations, and other characteristics to the design of tools, machines, systems, tasks, jobs, and environments to productive, safe, comfortable, and effective human use. That's kind of a mouthful. It's kind of confusing. So one of my favorite quotes is from the late, great Bob Wares, who was a pioneer of patient safety and human factors in the emergency department. He was an emergency physician who passed away well before his time, but he summarized human factors as the study of factors that make work easy or hard. It's like perfect emergency physician way of summarizing something up. So we want to make it easy to do the right thing. I say that all the time. We got to make it easy for the emergency physicians to do the right thing. And we can't do that without building correct systems to do that. All right, so we can apply stewardship to the definition that Dr. Japanis came up with stewardship. So what we try to do in our lab is apply information about healthcare provider behaviors, ability limitations, and other characteristics to the design of EHR, clinical decision support, diagnostic tests, behavioral interventions, and healthcare delivery systems to promote safe, effective, and judicious antibiotic prescribing. So that's sort of our foundational mantra of what we're trying to achieve with the lab. This is the SEEPS model. I don't know if any of you are familiar with the SEEPS model, but this is a sort of a foundational human factor systems engineering model that was developed at UW-Madison by one of my mentors on my K award, Dr. Carrion, who has since retired. But basically, this model is considered a standard systematic way to look at healthcare dilemmas and to make sure you're not having any blind spots in the way you're looking at the problem. So it's often used in sort of qualitative mixed methods analyses when you're talking to folks. You want to make sure you're thinking about each of these buckets and the external environment that wraps around the work system that you're dealing with. And so, for example, every work system would be different within the hospital. Like the ED is a different work system than ambulatory, which is different than the ICU, which is different than Gen Care, and surgical units, and et cetera. And so within those work systems, you have the people that are there. What are they bringing to the table? What kind of technology they have access to? What kind of organizational structures, policies? What's the physical environment? Is it chaos like the ED with people sort of pouring out in hallways and being crowded in the waiting room? What kind of tasks are they trying to get done? And what's their sort of regulatory external environment encompassing that? And so that work system that's been used another group, which has some names you probably recognize, Dr. Keller, Dr. Linder, Dr. Tama. So these folks are pretty big heavy hitters in the world of stewardship, and they use this model to characterize ambulatory stewardship in a systematic review from 2018, just to show the applicability there. And so we also have SEEPS. It's not only the work system, but it's how that feeds into process and outcomes. So we kind of have this comprehensive model. We got this work system and all the elements there. What are our target care processes? We get real specific about what we're trying to curb behavior on. And then we look at what are our important outcomes. So whether that's prescribing rates, durations, whatever we're trying to fix, that's what we kind of put in the outcome bucket. So it gives us a real nice structure to kind of apply to problems that come up. All right, so let's say we want to do an intervention in the ED. We have a problem. Does anybody have any examples of problems in their ED that they want to fix or would love to be able to fix? I could riff off of it if you have anything. I'm not going to be offended because I'll probably 100% agree with you that it's a problem. Has anyone tried tackling anything in the ED? Go ahead. Yeah. Oh yeah, the sepsis. Oh, I've written a couple lovely articles on SEP1. Um, so sepsis is a really interesting dilemma. How many of you are familiar with the SEP1 catastrophe that I would call it? It's an absolute catastrophe, okay? So SEP1 is the measure that says any emergency department patient with SIRS criteria, which is everybody who like walked in the heat into the emergency department, okay, has tachycardia and like increased respiratory rate in Wisconsin. You walk a block, you have increased respiratory rate and have tachycardia, okay? Um, so it's an incredibly overly sensitive metric that now is driven towards broad spectrum antibiotics immediately in the ED without any thought behind it. And so this is the reason why IDSA and ASAP combined forces to both strongly oppose SEP1, which now SEP1 has been given more teeth and is now actually being tied to financial penalties starting July 1. So this is going to be going down as one of the most catastrophic things since you need to give every patient in the waiting room who might have a sniffles, call them pneumonia and zithromycin from years back, if you remember that disaster. This will go down similar to that, and HCAP is another catastrophic thing that we did in ED for a long time. Um, but essentially, it's not getting any better. It's going to get worse. Like even at our shop, where I've been pushing for years to like ignore step one because it's kind of nonsense, that now the C-suite has gotten word that they're going to get penalized, and they're just basically pushing us to start giving broad spectrum antibiotics very, very early. And they have loosened up the step one list of what they consider like the appropriate antibiotics. So it doesn't have to be Zosyn or whatever. It can be ceftriaxone or something like that, but it's not any better. And it's really just pressuring those physicians to give antibiotics before they've done a proper assessment. So that is a huge problem. So I think for that problem, I would say step one is the problem because it's really pushing an artificial clinician response to very vague complaints that could have a variety of explanations. Yeah, go. CMS. Yeah. I mean, there's been editorials written about it in clinical infectious diseases. There's been newsletters. They've been in direct contact with them. They're getting a lot of pressure from the surviving sepsis folks. And so there's like this tension between the advocacy around sepsis, which is wonderful, right? When patients with sepsis need aggressive care, when they're hypotensive, when they're approaching septic shock, we need to get super aggressive. Like we know that in that population, time to antibiotics and the right antibiotics makes a huge difference. It's just that it makes no difference in people with SIRS criteria who don't even have severe sepsis, if you want to believe that's the thing. But so there's this really big dichotomy. Like we need to go full court press in one group. We need to let these people marinate and do a thorough assessment. And right now we're just bundling them all together and saying just blast everybody with antibiotics and let them sort it out later. And so that lack of nuance, I think, is what's driving a lot of the problem. So that's my understanding, is that they're getting a lot of tension between the ID folks, the ED folks, and the sepsis folks that are really focused on early goal-directed therapy and time to antibiotic. So yeah, so it's a conundrum. Anyone else want to dive in there? That was a great one. That was a Pandora's box a little bit. Anyway, okay, so let's just say we want to fix something. We have to start from somewhere. And so really what you want to do when you think of an intervention is kind of forget what you think you know about what the problem is. Because a lot of times people are working in different environments and they say, well, we just think that the ED folks don't know about this, or we think that they don't care about this, or if we could just teach them, then they would just do the right thing. And oftentimes those are just completely off base, and that is not what's driving the behavior. So you really have to uncover what's driving the behavior to know how to fix it. Because if you just implement something that's what you think is going to work, it's probably going to fail. So we'll start with going through a little bit of how you think about it as a work system. So the ED, one of the things that's really characteristic, they've done studies on this, is some people would argue it has the highest decision-making density of any occupation known to mankind. So we make more decisions per minute of our shifts than any other occupation. So there's a lot going on there around cognitive shortcuts and heuristics. So again, make it easy to do the right thing. How do we do that? And then there's unique barriers to quality care, a lot of staff burnout, a lot of turnover, rotating not only physicians, but also nurses. Sort of getting feedback to these people that are working rotating shifts can be challenging. So the International Federation of Emergency Medicine came out with a statement a couple of years back and say EDs cannot function without recognizing the need for a systems approach to quality. So this might give you some insight for those of you who don't work in the ED, or if any of you do. One of our mantras is anyone, anything, anytime, which I love about emergency medicine, is that we're just sort of there as the safety net for everybody, no matter what. This is a list of cases that I saw in one maybe fairly notable shift, but in one 8-hour shift, these are the cases that I saw. And so I've got a lot of things distracting my attention. Some of the abbreviations: gunshot wound, kid with croup, suicidal overdose, septic shock, delirium, pneumonia, appendicitis, miscarriage. Sometimes you throw in delivering a baby in the car out front in there. So essentially they have a lot of divided attention, right? And so if everyone's saying, this is our special little thing that you need to excel at and do really, really well with, you got to hit those metrics. So essentially just imagine someone's like really, really distracted and you want them to improve antibiotics, but like, how do we make that easier for them because of all this competing attention things? And this is Pat Cross-Carey, one of my favorite emergency physician researchers at Dalhousie up in Canada. And he's done a lot of looking at how emergency physicians make decisions, sort of metacognitive work. And it is a great quote. In few other domains of medicine is there such variety, novelty, distraction, and chaos, all juxtaposed to a need with expeditious and judicious thinking. So this was a direct quote from an article that came out right around the time I was getting started with my research career in emergency medicine, stewardship related stuff. This was written by an ID physician. And it basically, I thought, was a very overly simplistic view of why we overprescribe. And it said, we're less concerned about the adverse effects because follow-up is limited. Thus, we use antibiotics liberally. So essentially kind of implying that we don't really care what happens to our patients. So that wasn't really well received. But it was really a good motivator to try to understand actually what's going on. And at the same time, like Larissa and I were both starting our careers, and we were really motivated to kind of really do some deep dive and see what was really going on in the ED. And so we did. We did some studies looking at mixed methods work to identify what are the true barriers to stewardship around different things. So diagnostic uncertainty is a huge driver of poor prescribing in the ED. Is it cellulitis or pseudocellulitis? Is it MRSA causing that abscess, or is it something else? Or do I need to treat double antibiotics? Pneumonia, is that viral? Is that COVID? Is it flu, or is it bacterial pneumonia? Is it aspiration pneumonitis? Who knows? Is that asymptomatic bacteriuria? Why that person's having the dwindles? Or they, is there something else going on? Or they have a UTI? Sepsis versus non-infectious mimics. We already talked about that. That's just scratching the surface and getting to organizational factors, overcrowding, EHR usability issues, poor design of clinical decision support, malpractice concerns are a huge driver. We've interviewed folks who work in Florida where they have a really litigious environment. Illinois is not great for that either. And so when we talk to providers in Wisconsin where we have a really good environment, this never comes up as an issue. But when we talk to people that in Illinois and Florida, it does come up as an issue. And then you have the patient factors. Access to care. So a lot of times, if you work at a safety net hospital, you're dealing with a safety net patient, meaning someone who is not plugged into care. Your prescribing threshold is going to be very different than someone who has high literacy and has good access to follow-up care. So figuring out ways to connect patients with care could lower prescribing thresholds because you're actually not worried the patient's going to fall off the planet and never come back because they don't know when to come back or they're going to be sort of lost to follow-up. Sometimes patients will explicitly ask you or demand antibiotics. Happens way less than providers perceive it to happen, but it is a thing. And then obviously, if you're worried about health literacy, then you might be more likely to prescribe. Nice quote from Chirani back in 2014. The majority of stewardship intervention studies fail because they did not incorporate formal barrier analysis. So they're not targeting the true problem to actually change the issue. So when we think about it, we think about a process called intervention mapping. So we drill down very specifically, what syndrome are we trying to address? Is it pneumonia? Is it sepsis? Is it UTI, cellulitis, whatever? Which of the 5Ds or multiple of the 5Ds are we targeting? What is the setting? Is this ED? Is it ambulatory? What's the professional culture? What is the standard and why is it that way? And then what are the institutional factors? So we get really, really specific on drilling into the problem. So the first thing we do is, again, blank slate. We're starting from scratch. We're getting our systems engineers in. I'm gonna forget what I think is driving it, even though I work in the ED. Maybe I'm biased. So I'm gonna start with a blank slate, and first we're gonna watch. So we do contextual inquiry, which is basically where we follow around the physicians, understand what is the workflow, why are they making the decisions they're making, how do they do it in the EHR, what are the steps, what's the sequence, and it's just this painful, detailed processing of every little step, every little decision. Why are you clicking that? Why are you going there? The engineers, they love it. They dive into it. They're just like following us around like we're the lab rats, and they're just taking notes on everything we do, asking us questions. And we're like, I don't even know why I'm doing that. You know what I mean? Like you actually start to have metacognition when people are looking at you, watching your work. So they watch, and then we talk, we meet in qualitative either focus groups or semi-structured interviews to do a deeper dive on things and use that systems engineering model that we talked about. Then they sit down and design. So rigorous design, multiple iterations, getting feedback from end users kind of before we put it in place. And then we evaluate. We put it into the world, either in simulation models or we put it into the clinical setting. And then they do the whole thing all over again. It repeats. So now we're watching you use the intervention and doing the same process of contextual inquiry. So it's this never-ending cycle. Now, this seems incredibly laborious, but we're trying to actually do the work. So when we get the answers of what's going to work, other people can implement it much more easily because we're trying to do this very rigorous assessment and design process. So obviously everyone doesn't have the resources to do that at their local shops, but hopefully when we put stuff out, it can be applicable broadly because we've done the work. All right, so here's some of our qualitative stuff on UTI. Here's a quote from a paper we wrote a couple years ago. basically every geriatric patient should get a UA, EDRN with many years of experience. Um, so yeah, when I first went up to UW, I did all my training in Illinois. I worked at Loyola for a number of years before I went up to UW, and I figured out that essentially every patient in the waiting room was getting a urinalysis with reflex culture, regardless of like almost any complaint. And it was like, oh my God. So we looked at it and we looked at the idea of a reflex culture and is that appropriate or not? And we got rid of it. And then ID wanted it back because we missed a few cultures and it was this whole big rigmarole. But essentially, we whittled it down. So now we're not just sending urine with reflex cultures on everybody. They can get a urinalysis and we can decide if we want to add a culture on later. Hooray for clinical correlation. But essentially that's what you're dealing with. That's the uphill battle. And not even to mention like, oh, the urine looks weird, it smells weird, oh, it's gross, we need to culture that. I mean, these are quotes I hear every day, despite having like vastly tried to educate and raise awareness and people at our institution publishing on these myths about UTI diagnosis. So there's really no excuse. But again, people come in from the outside. We have a lot, like half of our nurses are travelers. So like literally they're just people that are transiently coming through every couple months and it's turning over constantly. So again, can we build better systems to prevent people that may have knowledge gaps from doing things that are just kind of off the wall? This is another correlate from a hospital medicine investigator, Iredall. Yes, I believe there is uncertainty. The patient is doing poorly for whatever reason, and you give an antibiotic in case they have a UTI. So, I mean, I guarantee you've all probably seen this, and this kind of just like makes you want to hit your head on the wall. But essentially, there's a lot of across the board provider nursing. There's a lot of education gaps, a lot of things, and a lot of like misbeliefs. They believe myths about this stuff. It's really difficult to change the perspective. So when we think about a mapped UTI intervention, so what is the problem? So the problem is older adults with vague systemic symptoms are often treated with antibiotics by the ED. And so why is that? Well, what we found out when we talked to the providers is that oftentimes they feel like they need to have a better diagnosis than grandma doesn't feel good to get someone in the hospital. And so when they make that call to the admitting hospitalist, they say, hey, this person's been falling a few times, they're really weak, the family can't take care of them. Well, that's great. What's the diagnosis? Uh, well, we did give them ceftriaxone for their possible UTI because they had some bacteria in their urine. And oh, sure, okay, that sounds reasonable. So you're admitting them for a UTI and maybe early urosepsis or something like that. It's like, okay, so it greases the tracks. It really just greases the tracks to make that phone call when you're dealing with 8 traumas and other crashing patients. You just want to call and have someone say, okay, I'll take the patient. That's what you're trying to do. So how do we combat that? But that is sort of a big problem, right, in the communication across the services. So one local community shop in Wisconsin near UW, with Dr. Redwood, one of my trainees who went to work there, he implemented a transdisciplinary protocol that extended all the way from long-term care facility, which was across the street. And they sent their patients straight over to the ED. They could just roll them on over. And when they came from long-term care, they showed up in the ED, and then they would get admitted for this failure to thrive, falls, weakness, confusion, delirium, whatever, which far more likely to be dehydration, medication effects, um, just sundowning, other sorts of things. So there's a lot of things, and you don't want to do early closure either, right? If the emergency physician just looks at someone and says, "Oh yeah, that urine you got in triage, there's some bacteria, it's probably UTI," well then they miss the subdural, the head bleed, or the toxic metabolic thing that's going on. So they came up with the no antibiotic observation protocol, and this has been very successful with them. So they got all the stakeholders together and they agreed that if older adults with altered mental status, no localizing symptoms, no stability concerns, and no clear alternate explanation with a positive UA will be admitted to the medical floor with no antibiotics for 24 to 48 hours while the hospitalist evaluates for more likely causes of these symptoms. If altered after 48 hours and no other explanation, then you begin treating for possible UTI. So fantastic, right? It kind of checks all the boxes. They're not septic, they're not deteriorating. Everyone agrees, the hospitalists, the emergency physicians, the long-term care folks, they all knew about this protocol. They all signed off and they got really good adoption because they had buy-in from all the stakeholders up front. They designed it to target the problem that was driving the prescribing. I think it's just a nice, really nice example of way you can work together and try to create systems, things that the ED folks didn't care. They didn't have an axe to grind about giving all these people antibiotics. They just wanted to get the patient admitted because so they had to figure out a way to kind of figure that. But yeah, go.
So, I mean, that's pretty clear, right? That
Another piece of this, something like that, it's like, oh, you know, it's never gonna allow for any type of moving.
Yeah, that's like even one level up from the levers, right? So like why don't we have codes that better reflect patients' needs? So can we advocate to get a code that kind of reflects? I mean, I think they call it failure to thrive is what the code they can use. They don't like that because it's pretty vague. And it means like, oh man, I'm gonna have to actually assess and like do some more following of the patient. It's a nice when it's in a little bump, like a little bow, and it's perfectly packaged up, and you kind of can see what's going to happen. The hospitalist is saying, okay, get antibiotics, gonna be here for 2 days. It's gonna be an observational admission. It's gonna be pretty straightforward versus, hey, I don't know what's going on with this patient. I'm not sure. This is what I did so far. I'm actually holding antibiotics because I know there's bacteria and I'm sure that this person has bacteria in their urine every day. You would check it every day of the week and twice on Sundays. So let's just hold the antibiotics and figure out what's actually going on. And then that might actually have a better conversation. Well, did you think about getting a head CT? Did you think about looking at the meds, having pharmacy look at their med list? So they can actually spur a conversation by being honest about diagnostic uncertainty. That's one of the other things that I love advocating is like, if you don't know exactly what's going on, don't anchor on that easy diagnosis and communicate that to the downstream provider so they know when they go assess the patient, they're going to do a much better assessment. They're not going to just sort of assume everything's figured out already. And so communicating that diagnostic uncertainty, I think, is another way of framing it that can help people kind of buy in, saying, do you want to know when I have a patient I'm handing off to you that I don't really know what's going on? And empower me to feel open to say that and not like embarrassed or saying like, oh, I don't know what's going on. It's like, no, you should embrace that uncertainty and even tell patients if they're going home, like, hey, I don't know exactly what's causing your symptoms. You need to follow up. You need to come back and whatever. I feel like emergency physicians often feel like we have to have that final definitive answer to do a good job. And I think we're doing a disservice to both our colleagues downstream and our patients by not embracing uncertainty when it's there. And this protocol was implemented at that community hospital, yeah, nearby the UW. Oh, I think it's like 100-bed hospital, 50 to 100 bed. Yeah. So not bad. It worked for them. Yeah. I keep telling Bobby to like write up the results because he won't publish it because he's like, I'm just busy. He's like an administrator guy now. He used to be a researcher and I got big on hospital admin. So, but I was like, you should write that up. That's so wonderful. And like the CDC's taken that thing and used it in their stuff and it's been, propagated. It should be. It should be. Yeah, it should be on there. So one other thing. So again, the other thing we had to address is the myths about UTI and UTI diagnosis. Again, so we went back. Oh yeah, go ahead. No, you're fine. Yeah, because they basically had a welcome partner on the other end who was going to make that friction and that resistance go away. So they'd almost say like, my understanding is because I didn't work there when they were doing this, but they would say we're using the asymptomatic bacteria protocol. Oh, okay, so this person's having problem, but you're not treating, like it was basically like they called it a thing, and so they could refer to that. And for them, it was great. I mean, they loved it because they didn't have to feel the pressure to just prescribe everybody antibiotics. Believe it or not, like we don't actually like giving everybody antibiotics, but there's these weird pressures that kind of force you to do it, or you feel like you're beholden to somebody's gonna come yell at you later or kind of like call you out, like, why didn't you do that or whatever. So if we can get them engaged, and I think it was because their quality leadership, and again, smaller groups are a little easier to manage sometimes. So there's probably a smaller group where they had a good champion. I don't talk about this in this presentation, but the key role of getting that ED champion, who's going to be your stewardship champion, hopefully someone on the operations side who has a role in quality, who's going to actually be bought in and be like, I'll be your partner. I'm going to bring the message to my people and kind of break it down in a way that shows them the value, right? So if you can have that value of not having to stress about making that call when you're like, I don't know what's wrong with this person, but they can't go home. That stress is horrible. And it's like getting rid of that is great. I think they really embrace that. That's yeah. There was, I don't know. I don't think they actually embedded it into the HR. I think it was just sort of posted and they just all kind of knew about it. Again, that raises issues for sustainability, right? If there's no like, if it's not baked into the system, it's hard. You get turnover in a couple of years, people forget about that UTI protocol and do they use it? And new hospitalists, I've never heard of that. What are you talking about? Is a UTI a thing? Like, yeah. So having order sets or a way to kind of flag that you're using that, or a button you can click that kind of activates that and links to the protocol would be super helpful from like a design perspective. But again, it was a smaller shop, so I don't really have a ton of IT resources either. But philosophically, it was just beautiful, you know. So this is one thing we did for design around urine ordering. So we found that again, there was just these terrible myths about sending UA. So we tried to, I'll blow over this. This just talks about like from a design perspective, how bad CDS can be if you don't really think about giving it to like the right person at the right time in the right formatting and the right vector and at the right time in the encounter. It can be too late, too early. Obviously, like death by BPAs are not great. You don't want to like BPA for everything and people just click like, what do I need to click to get rid of this thing? Like that's what they literally would think because they're again trying to run to that trauma that's rolling in and that new ambo that just arrived. So doing CDS in a way that's well integrated, that's not going to kind of drive people crazy so they don't ignore it, sort of alarm fatigue is important. Oh, this is a great little contrast. So Bob Weir, who I mentioned earlier, and Shauna Perry, who is another pioneering sort of human factors researcher in ED, they were writing about computer systems and other advanced form of automation have great potential to improve the quality and reliability of care, but current products leave much to be desired in the quality of their interfaces of workers and the workplace. It's like, okay, so like EHRs kind of stink, you know, at that time. That was from 2002. And so they wrote that about 20 years ago, a little over 20 years ago. And then we wrote a systematic review much more recently in 2019 that basically found that essentially all the CDS article that had been implemented in ED across indication, not just ID, had basically zero thought of design or human factors approaches mentioned in their methodology or the design of the interventions. So essentially, there's a huge gap on emphasis on design and human factors principles for CDS. So we went to our frontline providers and we did the qualitative work. We understood the workflows, and then we built our unit order. There's been multiple publications on this from our group and others, but essentially, we figured out that you need to call the order for what it is. So when you're clicking on it, like this is for suspected UTI only. This is not for being used for other random things, just for UTI only. It's got the decision support, like these are not indications for UA with reflex culture. Those are laid out there. And then you have to select one of the indications that we decided is appropriate for sending a urine culture on any patient. If you want to override this, it's possible, but we can audit that and see if you didn't select indication. And if you're selecting first one every time, we can also audit that and understand what your selection practices are when you're trying to just click through and get done with it. And so I can audit that and find out people and give them helpful academic detailing feedback. Let's put it that way. So this is just an example of how you can sort of enhance ordering and nest some of this decision support that targets these myths and these misbeliefs in others. All right, let's shift gears, talk a little about cellulitis. This is one of the areas I do most of my work in. We did a national survey of emergency physicians. They highlighted over half, or just under 40% indicated that diagnostic uncertainty is a huge driver of their prescribing for cellulitis. So essentially trying to figure out if that's actually cellulitis or not. Here's some nice photos that demonstrate why that can be a little bit difficult. You have cellulitis on the left there. Some of these other conditions that are gout, venous dermatitis, DVTs, venous ulcers with sort of erythema. You can get bug bites, burns that are healing that kind of get red on the rim and the edges of the burn. All sorts of things that kind of look cellulitis-ish, but are not truly cellulitis. So what's the magnitude of this problem? This is probably the best article that's been done on that topic from Wang et al. In JAMA Dermatology 2017, where they looked at 259 consecutive admissions. This is not even outpatients. This is just the admissions. And they found when dermatologists saw those patients when they hit the floor, a third of them did not have cellulitis. These are people being admitted for IV antibiotics. The rate of people being discharged on oral antibiotics for cellulitis is probably much higher than that because, again, this is what you think is like the most slam dunk cellulitis cases that you need to admit to the hospital for whatever reason. And so they projected that nationally somewhere up to 100,000 unnecessary admissions per year for cellulitis, hundreds of millions of healthcare costs, C. diff cases, resistance, obviously a problem there. So this was a big impetus for us to sort of dive into this a little bit more. So we published a study in 2022 where we looked at a national sample of emergency physicians and tried to understand what is driving the prescribing, the barriers and facilities to stewardship for skin and soft tissue infections with the SEEPS model as the anchor. Here's a quote. So you've got the textbook redness, warmth, and fluctuance, and then you've got the patient in front of you who didn't read the textbook and could have any mixture of those symptoms or partial symptoms. I always prescribe these patients antibiotics because I don't know what the wound culture is going to show. If it's positive for MRSA, I don't want the patient to come back because I didn't prescribe antibiotics. So these are just a couple examples. We did in that publication, you can see we broke down the barriers on the left column. We did intervention mapping for all of them because each barrier has its own unique potential intervention or solution. This is a little bit small, but I can go through a few of them. So one of the things that came up was lack of access to care. So can you set up a program where you do community paramedicine or you do telehealth visits for patients that are discharged without antibiotics that may have fallen through the cracks to make you feel better that they're going to get a reassessment. So you don't feel like you have that one chance to prescribe for that probably not cellulitis, but they're going to get follow-up. Is that something that could help? What about patient expectations? These demands for antibiotics. Like last time my legs looked like this, they gave me an antibiotic and it got better. They admitted me and I got better after 2 days. Like you don't have bilateral cellulitis, you have stasis dermatitis, you haven't been wearing your compression dressings, and it's not cellulitis. Last time they admitted me, it was like okay. So there's providers whose actual compensation is driven by patient satisfaction metrics. So you get paid based on if people like you and think you did a good job. That is a terrible idea generally, especially in the opiate crisis and with antibiotics. Those are the two most obvious reasons we should not do that. But I mean, I'm not saying don't track it. I'm saying don't link it to somebody's pay necessarily because there's going to be a very perverse incentive to just do whatever the patient wants if you think it's not super egregious. So what if you could flag those cases where you feel like someone's inappropriately demanding an antibiotic? Can you just say, please exclude that from my satisfaction metrics, and this is why, flag it, or some button you could click? Would that be helpful? Diagnostic uncertainty. There's been studies looking at what happens when we do rapid MRSA PCRs of wound. So the purulence culture. Can we reduce double prescribing in those cases or reduce prescribing for really complicated abscesses that have very minimal benefit from antibiotics, if any? What about pseudocellulitis? There's thermal imaging cameras. There's other kind of biomarkers we can use. Can we improve the diagnostic accuracy besides, I looked at it, it looks like cellulitis. Maybe I touched it. In many cases, they don't even actually document that they felt the heat of the wound, which is a big part of cellulitis. Fear of adverse events. What if patients were giving a tool to explain what are the risks, the pros and cons? Like if I'm going to prescribe, what is my likelihood of cellulitis versus my likelihood of having a bad reaction to this or hurting my microbiome or causing an adverse event? We're not having those discussions about shared decision making that's transparent about risks and benefits. So what if we had a tool? Would that be helpful? So we're kind of creating these different potential solutions because we wanted to study them in a simulated environment and see if they actually move the needle on prescribing in a case vignette setting. And then provider knowledge gaps, like what if we just told providers as they're about to prescribe or they do prescribe, be like, do you know that 30% of cellulitis cases are actually overdiagnosed and they don't actually have cellulitis? When we brought that to our qualitative interviews, that Wang study, they were like, that's ridiculous. Like no one believed it. No one thought it was possible. No one bought that at all. And we're like, well, I kind of trust the two independent dermatologists that looked at it. Like, yeah, so it probably is true. And then that finding is consistent, that 30 plus or 30 to 40% misdiagnosis in ambulatory care and primary care. Every clinic, every setting, it's been very, very consistent, that misdiagnosis rate. So I think it's a good accurate estimate, about a third of patients. Yeah, go ahead. Love that. And I love the outcomes tracking thing, and we're actually working on a grant to sort of feedback final diagnosis to the emergency physicians on this stuff. Like, for example, did your patient get continued on antibiotics after you initiated them? Did they get discharged with a completely different diagnosis than you thought they did? They got sent home with CHF when you thought they were pneumonia. So right now there is no clear feedback loops around that exact thing. And nesting that within community paramedicine would be awesome too. Is like, oh yeah, by the way, that patient you sent home never needed antibiotics. They did fine. We did some wound care, we compressed them, we elevated them, they did fine. Great, that's awesome. That gives me that positive feedback that I did the right thing. But right now they're just going into the ether and you don't know, right? And so you can see why someone would be, what's the lesser of two evils? Do I just prescribe and I'm covered? They're not going to come back the next day with worsening infection, sepsis, or whatever. So I love that. I love that idea. But our group is doing community paramedicine. One of the investigators in our department is doing that for patients with fall risk and with certain geriatric patients. We haven't quite applied it to the ID topics, which I would love to do. I want to collaborate with them on that. So what we did, then we did a factorial survey. You got a 5-minute warning there. Okay. We'll be fine on time. So basically what we did is we did this very rigorous process where we developed these clinical vignettes where there was kind of like this equipoise of diagnosis. It was like, yeah, that could be cellulitis. It could not be. It had some features. And we tuned it. So we just tested it on providers and kind of like saw how many people thought this was a case representing cellulitis or not. And it was about half and half. So essentially it was like a really equipoise case. And then we layered in these interventions on top of it in a factorial design where we'd, show either one or two of the interventions or just one. And we kind of randomized the mixing of the interventions. So you could either get 0 interventions or all 5. And through complex statistics, which are above me that the statistician did, they basically tried to figure out which of these scenarios or these combinations of interventions that we could possibly do in a simulated environment might have the biggest bang for your buck. The reason we do that is because before we go and implement it in the real world, which is super costly, is like going to cost a $2.5 million grant, let's try to do it in a virtual environment and see like what are our high yield targets that we think are most likely to work and change behavior, prescribing behavior. This is a really cool radar plot. Just if you look around the wheel, each of those wheels is one of the scenarios. The possible combinations is each one. And when you look at the lines, are the probability of prescribing. So as you go out towards the out of the wheel, that's higher prescribing rates and inner is lower prescribing rates. And just as proof of concept, if you step back and look at it, for both cellulitis and abscess cases, which are the two lines, cellulitis is the solid and dash is abscess, you can see there's a lot of variability in the likelihood of prescribing based on what stimuli we were giving them in terms of those potential interventions that we nested into the vignette case. So just proof of concept, like we were actually changing likelihood of prescribing by giving them different interventions in the vignettes. So that was the first thing we were like, that's cool. We actually saw a difference there. And then we looked at which ones actually moved the needle the most. They thought if we could have a imaging modality to quantify the heat of the skin, and that somehow correlated to the likelihood or not of having cellulitis, that would actually convince them to prescribe or not prescribe. And the second one I thought was really powerful and equally effective is that the patient raising concerns that I'm worried about the downsides of antibiotics, just verbalizing that in the case, reduced prescribing. So we went, okay, let's see what's going on with this thermal imaging stuff. So we did some digging into thermography. So this is another paper from a group out at Harvard, Coe et al. From 2018, where they looked at surface thermal imaging cameras. So these are the things that like they use in airports to screen people with fever and Predator. For those of you who are old, the Predator vision, that's Predator vision, Arnold Schwarzenegger in the cold mud. But so that's basically you have these cameras, but now they can plug into your iPad or your iPhone and you can walk up to the bedside and hold it over there and you can look at the patient's skin and kind of hover over them and get real-time thermal data off the skin. And so what Coe et al. First showed in a smaller project, about 40 patients, they found significant differences between a cellulitic limb and the control limb, and also big differences in the difference between a patient that has pseudocellulitis, as determined by a dermatologist, a mimic of cellulitis, has a much lower temperature gradient than a true cellulitis. So basically, cellulitis burns much hotter than pseudocellulitis. We know that from Coe's paper. We went and improved on that significantly, but basically, here's what it looks like when we get the images. There's a FLIR camera that's providing these. And so you can see a healthy limb. We can get a data of T max, T average for the selected area, the T min, and then you can compare that to the affected limb. So we went ahead and replicated that study in over 200 patients and undifferentiated. They had a 6-panel expert physicians adjudication that included infectious diseases and dermatology to try to we really wanted to get the right answer if this was a cellulitis or not. And we basically found very similar findings. About a 3-degree gradient between the cellulitis cases as compared to a less than 1-degree gradient in the pseudocellulitis cases. So again, through fancy statistical modeling, we came up with a cutoff for T max in the temperature that could actually predict cellulitis with a good reliability. We published that in JAMA Derm just a few months ago. And so we're now working on what's the next step of implementation. How do we find a way to bring these cameras into the ED environment? Who's going to take the pictures? Who's going to process the thermal data? How is it going to feed into a calculator that's going to give you a probability? So we have a lot of work to do, and we also need a more diverse sample. We did this in Wisconsin, not a lot of individuals with skin of color up there. So we really need to broaden our sample to make sure this performs in other populations. We have a grant under review with HRQ to do that currently. Hopefully we get funded, but essentially a lot of work to do before this is prime time, but it's really promising that we might have a new novel bedside diagnostic that we can really just apply and get some quantitative data on heat to actually help the physicians make the right decision around cellulitis. And take-home messages. Okay, healthcare takes place, antibiotic prescribing takes place in complex work systems, especially the ED. Think about the elements and the interactions. Avoid the fundamental attribution error. Don't blame the individual, blame the system. We need to build better widgets, ways of doing it. Forget what you think you know when you're trying to build interventions, and design custom interventions to target the most salient barriers to prescribing. And design for Homer, for the Simpsons fans out there. Okay, so I'll take questions. I think I'm okay. Okay. All right, thanks everybody. Any questions?
I'm gonna ask you because I'm kind of like in the hospital. I'm one of the he's got this. And when I have this one executive who's there. He's
She's a long-term care doc or an ED doc?
She's like, nursing,
Oh, wow.
sitting.
Feels all the, where's all the
Yeah,
heads?
well,
Starts with the long-term care, runs over, sees the patient ED, then admits them. Okay.
not really easy to talk to. I don't know if he's, yeah.
She's
That's a lot.
okay.
I'm glad.
Good.
So, two papers, and text, one of them where they got together, we had a reflex criteria, and we saw the positive predictive value of like, real stories, so there was another paper I looked at, and they came with all greater than 10 white cells. I had that thing.
There's a lot of papers looking at the optimal thresholds for white blood cell presence in the reflex culturing. We've at our shop we settled on 5, and some have done 10. We think that has better performance. 10 probably has better performance in individuals that are chronically catheter dependent, because you want to set the bar a little bit higher in that population. You know, aside from the idea of missing a culture, I'm not a huge fan of the reflex culture. It's kind of it saves one step, and if you're really ordering it because you suspect clinically that there's a UTI coming. But I'm not a huge, I don't like when people are getting things ordered that they haven't explicitly been thoughtful about ordering. And so I really like when the provider has to make that call of like, you know what, I'm so suspicious that this is a UTI, I'm going to go ahead and order that individual culture. I know from an operational efficiency standpoint, it adds some value and things don't maybe not fall through the cracks, but a lot of times labs will hold the urine and you can add a culture on at a later point too. So it's not like you have that one moment in time to do it. You can call up and say, hey, you know what?
You're that person.
Yeah.
They papers, we sit out those. They're
Yeah.
gonna onto them, then you pour off stuff.
Yeah. Now that's, I think that would be a great intervention to make sure that everybody's doing that. There's some really nice papers on like deconstructing your analysis. That's like one of my favorite papers of the last 5 years. It's like wonderful. It's basically saying, you know, we really need different urine orders for different indications. And so we shouldn't just have the urine with reflex, urine with plus culture. It should be like urine when you're worried about ketones in the urine, urine when you're worried about UTI. Like it really needs to get that specific because sometimes we're just looking for urine electrolytes or we're looking for protein or whatever. So it's not always for infection. Yeah.
Yeah, that's, I mean, one of those papers did say that right off reflex, reflex when you're going to cut down on it, but I think, so.
Well, it does in comparison to I'm doing universal culturing. If the practice is everyone that gets a urine gets an automatic culture as well, and there's no reflex criteria, then it will. But if you're doing thoughtful ordering where you have to order them individually and it has to be sort of uncoupled, then it wouldn't because it's just reflexing, so it's automatically going to trigger when there's no clinical indication. So compared to yes, routine use of culture in everybody, it's going to go way down, right? Because now it's like we actually have some criteria. So I think that's the sort of the smoke and mirrors a little bit is like, oh, reflex culturing helps, right? It reduces culture rate. Yes, but it depends on what your baseline practice was. And if your practice is everybody gets a culture in every analysis, of course it's going to reduce that. But that's even worse. So I would definitely select reflex over the universal culture for every urine, regardless of why it was sent. Absolutely. But yeah.
Um, for, um, um, like, how do you, cause it's just, yeah, the risk is very high and, do you have any advice for like, stewardship programs that might be easier, cause they were like, are we gonna refer them when we get to?
Yeah. It's hard, right? Because I think I think that's a lot of sort of bluster, like I'm going to get sued for what? So certainly if you're admitting the patient, they're going to be watched. They're not going to be falling off. It's definitely for the discharge folks. I hear that all the time. Like they're worried what's going to happen is the patient's going to go back to the nursing home. They're going to get septic. They're going to come back in septic shock. They're going to have a poor trajectory. And then they're going to link back and say, well, doctor, clearly there was bacteria in that urine here and you just blew it off and blah, blah, blah. So there is some validity to the thought. I think it's a little bit overblown. Certainly, you know, my antidote to that is always engaging the patient. It's really the shared decision making, because if you can document equipoise, meaning like, hey, we did find bacteria in your urine, however, that's highly unlikely to be a UTI based on your clinical presentation. And if you could document a shared decision making conversation where I offered treatment, I told the patient that this was probably low likelihood and they selected to go ahead with therapy, versus I said they agreed they wanted to withhold and do observation at this point, or the family did, say it's somebody with dementia who can't make that decision. I think those are powerful things to document that protect you medical legally, where you could say, we had this conversation. We explicitly talked about the risk of UTI. The likelihood was low. It wasn't zero, but it's low. And it's not all benefit from taking an antibiotic, right? There's harms as well. The problem is that patient goes home and didn't have a UTI and gets C. diff and dies from toxic megacolon. No one's going to think they're going to get sued for that. But really, in reality, they should, right? Because they gave an inappropriate, unnecessary antibiotic. The culture grew out nothing, and no one ever stopped the antibiotic, and the person had a complication. But somehow that feedback is never making it around, and it's not really, it's harder. I don't even think the legal field has like caught on to that those are other things that they could be looking at. So it's tough. But yeah, that's what I would say, is bring the patient and make it shared decision. Sure. Yeah.
Because I work a lot on community because they need to have ideas about it, so they fail POs. And then their duration can be extended to 14 days or so. Yeah, right, if they get it in patients and then get prescribed the other antibiotics. So that's one thing I'm trying to work on with like, but
Well, that's like a whole other talk, but there's a couple of tips I can give you on that. So we've published some data on Aretavansin and how to use that and develop protocols for appropriate use in ED. The eligible patients where that would be appropriate. So kind of going really upstream from this, like most patients that we admit from the ED for cellulitis do not need to be admitted at all. So when they're telling you like, I'm admitting this person, why are you admitting this person? Well, they're high risk. Okay, maybe. But when Talon et al. Looked at this a couple years ago, like probably half of all the admissions, I believe it was half or a little more than that, were completely not indicated. So these people are getting admitted for antibiotics for high risk. There's no basis to that. There's no actual evidence that they have higher treatment failure. In all the studies, like not a single patient dies. No one comes back with really bad septic, like very, very low, less than 5% of people. So the risk of cellulitis progressing to systemic is very, very low. There's not great data that brings people in for IV antibiotics is beneficial. A lot of times this treatment failure is because they drew a line around the ring of cellulitis, which they should never, ever do. That is a horrible thing to do, because it's totally normal for redness to expand for 48 hours in the setting of appropriate treatment. When pain is improving and intensity of redness is improving, it's going to spread out of the margin for 48 hours. That is completely normal. But I can tell you infinite amount of cases where people come back the next day, 12 hours later, it went outside of the red ring. Is it less painful? Yeah. Are you feeling better? Yeah. Is it less red? It's less intensive red? Yeah. Okay, so it's working. It's working. You need to go home. But we admit those people on IV Vanco all the time, constantly. So look for that. That's a really easy target. Stop drawing rings around cellulitis. Tell patients it's going to get bigger for the next 2 days. Watch for pain, watch for redness, and don't admit so many people that don't need to be admitted in the first place. Now, there's certain populations that Aretavansin is like an excellent choice, fantastic choice. People that are not connected with care, people that are not compliant with their medications, people that have had like issues with being in the hospital, they're going to get more frail, they're going to be compensated in the hospital. So I think it has its niche, finding the niche, I think is the title of our paper, but like, how do you find the group that's going to be the best we give that? And it's probably about 8 to 10% of patients are really good targets in the right ED for that kind of long-acting agent. And certainly if you want to use it in the inpatient to get them out earlier, but yeah, absolutely. But I think also we need to look at the duration. I love all the work that people have done on the pharmacy side on showing how these shorter and shorter durations are equally effective for cellulitis, UTIs, high load, pneumonia. I mean, we really should be looking at cutting down these durations dramatically and limiting our prescribing. So, yeah, I'm happy to talk more about that specifically or that paper.
Information for analytics workshop. I know this is really interesting. I want to take off and
I'm happy to chat for a few minutes, for sure.